Have you ever finished a course of antibiotics and just felt off? Your gut doesn't feel quite right.
Yeah, that slight rumble or discomfort.
Exactly.
Hmm.
Well, today we're going to dive into one specific reason that might happen. It's a condition called pseudomembranous colitis.
And it can actually be quite serious in some cases.
Right, so we're going to unpack this.
Yep, using clear, focused info. Think
Yeah.
of it like high-yield revision notes, giving you the key facts without the dense textbook stuff.
Perfect. The mission today is to give you a really solid, memorable understanding of pseudomembranous colitis.
Covering everything from what it is, the causes, risks, right through to complications.
And we'll throw in some memory aids, too. Okay, let's jump in. What exactly is pseudomembranous colitis?
Okay, so simply put, it's inflammation. Inflammation of the colon, your large intestine.
And the pseudomembranous part?
Right, that refers to these things called pseudomembranes that form inside the colon.
Not actual membranes, then.
No, not true biological membranes. They're more like layers made up of fibrin, that clotting protein mixed with inflammatory cells and dead tissue, necrotic debris.
And what triggers this inflammation in these layers?
The main trigger, the primary cause, is an infection, specifically with the bacterium called Clostridioides difficile.
Often called C.diff.
Exactly, C.diff. That's the key player here.
So if C.diff is the culprit, how does it actually cause the problem? What's the etiology?
It really comes down to the toxins produced by the C.diff bacteria.
Toxins, okay.
Yeah. See, normally, your colon is full of beneficial bacteria, your gut microbiota. It's a balanced ecosystem.
Right.
But when something disrupts that balance, and this is often after taking antibiotics, it clears the way.
Clears the way for C.diff.
Precisely. There's less competition, so C. diff can overgrow. And as it multiplies, it starts pumping out these toxins that damage the colon lining.
Ah, so the antibiotics trying to help with one infection can inadvertently create an opening for this other problem.
That's a perfect way to put it.
Oh, are there other things that make someone more likely to get this? Other risk factors?
Oh, definitely. Besides the big one, antibiotic use, other key factors include being in hospital, especially for a while.
Okay.
Also, advanced age is a risk factor. Having a weakened immune system, so immunosuppression,
Right.
and having other underlying gut conditions can also increase susceptibility.
Let's focus on those risks a bit more. You mentioned antibiotics are central. Are certain types worse than others?
Yes, that's a really important point. Recent use of broad-spectrum antibiotics is a major red flag.
Broad spectrum meaning they hit lots of different bacteria.
Exactly, both the good and the bad in your gut. Some key ones to remember are clindamycin, fluoroquinolones like ciprofloxacin,
Okay.
and cephalosporins. Actually, here's a quick memory tip. Think CFC.
CFC.
Clinda-fluoroceph. Helps it stick.
Nice. CFC. Got it. And the other risks?
Right, so prolonged hospital stays or living in long-term care, more exposure risk there. And things that weaken immunity, like, say, immunosuppressive drugs or chemotherapy. Plus, existing conditions like inflammatory bowel disease, they all play a role.
Okay, so we've got the bug, C. diff, and the risk factors like antibiotics, hospital stays. Now, how does it actually work? The mechanics of it? What's the pathophysiology?
So C. diff produces two main toxins. They're simply called Toxin A and Toxin B.
Creative naming.
Yes. And what these toxins do is directly damage the cells lining the colonic epithelium.
Okay, direct damage.
Yes, and that damage leads to inflammation and injury to the inner lining, the mucosa.
And the pseudomembranes.
That's a result of the inflammation and the ulceration. Those pseudomembranes are basically collections of inflammatory fluid, fibrin, all accumulating on that damaged surface.
Right.
But there's more. Toxins A and B also mess with the fluid balance. They stimulate the colon to secrete more fluid, and they make the lining more permeable, leakier.
Hence the diarrhea.
Exactly. That's a major reason for the diarrhea, and also why patients can get electrolyte imbalances, losing important salts. So it's a double whammy: direct damage and fluid disruption.
Nasty stuff. Okay, so if someone comes in with symptoms like severe diarrhea, abdominal pain, what else might be going on? What are the differentials doctors need to consider?
Critical question. You always have to think about other possibilities that look similar.
Right.
Well, other infections that cause colitis. Things like Salmonella, Shigella, Campylobacter.
Common food poisoning bugs.
Right. Maybe a memory tip here. Things SSE, Salmonella, Shigella, Campy, common gut spoilers.
SSC. Okay. What else?
Then there's ischemic colitis. That's when blood flow to the colon is reduced.
Okay.
Inflammatory bowel disease, so Crohn's or ulcerative colitis flares can present similarly.
Right. By BD.
And even some drugs, particularly NSAIDs, non-steroidal anti-inflammatories, can sometimes irritate the colon and cause drug-induced colitis. So yeah, several mimics to rule out.
It seems like quite a list. So, switching gears slightly, how common is this condition? What's the epidemiology look like?
It's actually pretty common, especially in healthcare settings. It's a major cause of nosocomial diarrhea that's hospital-acquired diarrhea worldwide.
Wow, okay.
Interestingly, maybe around 2% of the general population might just carry C. diff without any symptoms. Asymptomatic carriers.
Just living there harmlessly.
Usually, yes, until something like antibiotics disrupts the balance. And concerningly, the incidence, the number of cases, seems to have been increasing over recent years.
Why is that?
Likely due to factors like antibiotic resistance, tougher strains of C. diff, and probably better transmission within healthcare facilities. It's a significant challenge.
Definitely sounds like it. Okay, so what would someone actually experience? What are the signs and symptoms, the clinical presentation?
It's quite a spectrum, really. It can range from fairly mild diarrhea all the way to severe life-threatening colitis.
What are the common things to look for?
Frequent watery diarrhea is key. Sometimes it can even be bloody. Abdominal pain and cramping are very common. Fever, too.
Okay.
And you might see systemic signs of infection, like a fast heart rate tachycardia or high white blood cell count, leukocytosis on blood tests.
And the severe end of the spectrum?
Yeah, that's where it gets really dangerous. You can see things like toxic megacolon, where the colon gets massively dilated and shuts down, bowel perforation, a hole in the bowel, or even septic shock. Very serious.
That underlines why getting a diagnosis quickly is so important. How do doctors figure out if it is pseudomembranous colitis? What investigations are done?
It usually starts with strong clinical suspicion. You know, the symptoms plus that history, especially recent antibiotic use.
Right, putting the pieces together.
Exactly. Then lab tests are crucial. The main thing is testing stool samples.
What are you looking for in the stool?
Primarily, the C. diff toxins, Toxin A and Toxin B. There are specific assays for those. Or you can use molecular tests like PCR to detect the actual DNA of the C. diff bacteria.
Okay. Are scans or scopes ever needed?
Sometimes. If the diagnosis isn't clear or to see how bad the inflammation is, a doctor might do a flexible sigmoidoscopy or even a full colonoscopy.
Actually look inside.
Yeah, that allows them to directly visualize the colon lining, and they might actually see those characteristic pseudomembranes.
Got it. So once it's diagnosed, what's the plan? How is it managed?
First step, and this is really important, stop the antibiotic that likely caused it, if that's possible and safe to do.
Right. Remove the trigger.
Exactly. Then you need specific antibiotics to target the C. difficile itself.
So antibiotics to treat a problem often caused by antibiotics.
Kind of ironic, isn't it? The first line choices are usually oral vancomycin or fidaxomicin.
Vantamidoxo or Fidaxo.
Okay. Metronidazole is sometimes used as an alternative, maybe for milder cases or if the others aren't an option.
And anything else besides antibiotics?
Oh, yes. Supportive care is vital. That means managing fluids, often IV fluids for dehydration, replacing lost electrolytes, and really closely monitoring the patient for any signs they're getting worse or developing complications.
Makes sense. So what's the general outlook? If someone gets this, what's the prognosis like?
It really varies. It depends on how severe the infection is, the person's overall health, any other conditions they have, and, crucially, how quickly treatment gets started.
But generally?
Generally, the good news is that most cases respond well to the right antibiotics. Symptoms tend to resolve, and the colon lining heals up.
That's good.
However, there's a significant catch. Relapse is common.
It comes back. How often?
Yeah. Roughly 25% of patients might experience a recurrence after they finish their initial treatment course.
Wow, 1 in 4. That's quite high.
It is. It's a major challenge in managing C. diff.
Are there other complications besides relapse to worry about, especially in severe cases?
Yes. We touched on the really acute severe ones. Fulminant colitis rapidly progressing to toxic megacolon, bowel perforation, septic shock. Those are emergencies.
Life-threatening stuff.
Absolutely. And beyond the immediate danger, that risk of recurrent infections is a big deal, especially for vulnerable people. And even after the infection clears, some people can have longer-term issues.
Like what?
Things like developing post-infectious irritable bowel syndrome, IBS symptoms, triggered by the infection. Or sometimes just persistent chronic diarrhea that lingers.
Okay, so let's try and pull the key takeaways together. Pseudomembranous colitis, inflammation of the colon.
Caused by C. difficile toxins.
Often after antibiotics mess up the normal gut bacteria.
Right. Key symptoms are diarrhea, abdominal pain, fever.
diagnosed mainly by stool tests, looking for the toxins or the bug's DNA.
And treatment involves stopping the offending antibiotic if you can, and starting specific ones like vancomycin or phytoxamycins, plus supportive care.
And while most recover, watch out for that relapse rate, about 25%, and potentially serious complications.
That's a really good summary. Hits all the main points.
It really makes you think, though, given how common antibiotics are, what steps can people and healthcare providers take to try and minimize the risk of this happening in the first place?
That's the crucial question, isn't it? And, as we learn more about the gut microbiome, it makes you wonder how that understanding might change how we prevent and treat C. diff in the future. Maybe manipulating that ecosystem somehow.
Fascinating stuff. Definitely something to ponder. If you listening want to dig deeper into this or other key medical topics for your revision or just understanding, do check out pastthemsra.com.
And freemsra.com as well. Both are excellent resources for clear, high-yield medical information. Understanding conditions like this is so foundational.
Absolutely. Well, thanks for joining us on this important deep dive today.
My pleasure.
We'll catch you on the next exploration.